Hello, hi, I'm Dr. Radhika, Senior Consultant Obstetrics and Gynecology from BirthRight by Rainbow. So today I'm going to discuss about anemia in pregnancy and a small chat even about diabetes complicating pregnancy. So most of you all know that when you come to when you become pregnant and come to the antenatal checkups, so the first test what we do is to see how your hemoglobin status is. As you all know, anemia can be due to many various reasons. And the most common anemia which we come across during pregnancy is the iron deficiency anemia. And today I thought that would be the most important topic to be discussed to all the would-be mothers, as well as during the postpartum period, how to improve your hemoglobin status. So iron deficiency is the most common deficiency in the world, affecting more than 2 billion people globally. Effective management is needed to prevent adverse maternal and fetal outcomes, including the need for red cell transfusion. So red cell transfusion, I mean, is blood transfusion. So how do we define anemia? So iron deficiency basically represents a spectrum ranging from iron depletion to iron deficiency anemia. According to the World Health Organization, anemia is defined as less than 11 grams per deciliter in the first trimester, less than 10.5 grams per deciliter in the second and the third trimester, and less than 10 grams per deciliter in the postpartum period. So this is during pregnancy. If the woman has her hemoglobin levels very less, or if she is a patient of chronic anemia, not responding to the management earlier before she became pregnant, she probably has to be evaluated with a hematologist to know what is the reason for anemia. Is it because of anemia per se due to iron deficiency or vitamin B12 deficiency or a folic acid deficiency? And more so, it is the nutritional deficiency or nutritional anemia in India, and to rule out even other causes of anemia, that is hemoglobinopathies. And today I am not going to discuss anything about the hemoglobinopathies. So coming to the prevalence of iron deficiency anemia. See, iron deficiency anemia affects about 1.62 billion people globally, corresponding to 24.8% of the world population. You can imagine it is about 1/4 of the world population, more so in the developing countries, including the developed countries also do have these patients with anemia. According to the WHO, in 2008 itself, they have said that 40% of the preschool children and pregnant women have iron depletion. So why is it that iron is so important, and iron deficiency anemia diagnosis is so important, and what are the effects of iron deficiency on pregnancy? So this iron deficiency can affect the mother as well as the fetus or the baby. So in the mother, there is increased chance of preterm delivery. So what we mean by preterm delivery is when you deliver before 37 weeks, then it is known as the preterm delivery. So the complications for the mother as well as for the baby during this preterm delivery will be increased, and the risk of her having a preterm delivery next time is also increased. There's an increased risk of antepartum hemorrhage and postpartum hemorrhage. This is, but the deficiency of vitamin B12 or iron deficiency can lead to bleeding during pregnancy, and if it occurs after the pregnancy, it is known as the postpartum hemorrhage. So because of all this, there is increased morbidity in the patient or in the woman, and if she has any postpartum hemorrhage, and this iron deficiency in fact adds up to the problem, leading to increased chances of mortality. In the fetus, when the mother is having iron deficiency, the babies also will be of low birth weight and intrauterine growth restriction. That is, the babies will not be able to develop according to their gestational age, the weight of the baby, and that there will be a growth restriction during pregnancy. And even after birth, the baby will be having a neonatal anemia, because as like during pregnancy, the baby's hemoglobins are very high, that is above 20 grams per deciliter. But whereas as soon as the baby is born, this hemoglobin breaks down and comes to the normalcy, that is between 12 to 15 at birth. But then when the initially during pregnancy itself, the anemia starts off in the babies, the anemia continues in the neonatal period, and that will be leading to the failure of thriving for the babies. So what are the symptoms and signs of these of iron deficiency anemia? They're usually non-specific unless the anemia is severe. So the most common symptoms are fatigue. Fatigue is seen in 95% of the women, that they feel very tired as soon as they start working or talking, and they will not be able to climb stairs. They feel very, very weak. They may have pallor, that is, some people may be pale looking, and usually they think that they have become little, fair in complexion, but you need to rule out this pallor, that is which is due to anemia. Many people do have recurrent headaches. They can also have palpitations because the heart needs to function more or beat more to supply the necessary oxygen to all the blood cells. And this all adds to dizziness, because the patient or the woman, when she gets up or walks, they start feeling dizzy because of this anemia. So as you climb stairs or when you walk fast, some people may have shortness of breath, and because of all this going on internally, the patients can be very, very irritable. They cannot concentrate on their routine daily work. Some people also complain about the hair loss. So what are the signs of these anemia? So one is, when you look at them, they may be pale looking, and they may have changes on the nails. The hair may be brittle, and sometimes if the anemia is severe, they start having a shortness of breath as well as the generalized edema, and sometimes they may have even heart failure because it is a severe anemia. So how do we diagnose this iron deficiency anemia? So the most common test, as you all know or aware of, is the complete hemogram. That is, we estimate the hemoglobin estimation. So hemoglobin per se gives us what is the amount of blood in your body, which gives us whether you have is anemia or no. The other things what we do is the serum ferritin, which is very important, and this serum ferritin reflects the iron stores. So whenever a woman comes with low hemoglobin, we try to check the serum ferritin levels, and this will give us a direct reading about the iron stores. So when you don't have iron stores enough in your body, then we have to replace the iron. So whenever a serum ferritin level of less than 15 micrograms per liter is seen, this indicates that the iron depletion in all stages of pregnancy, and we need to immediately start treating. But if a level is less than 30 micrograms per liter, the treatment should be considered, and that could be either by a diet, or it could be either by oral supplementation and sometimes injectables, and so that the iron depletion can be corrected. So management of iron deficiency anemia. So how do we manage? See, the most important management for iron deficiency anemia is the dietary advice. As the statistics tells us, the average daily iron intake from food for women is about 10.5 milligrams, and only 15% of the dietary iron is absorbed usually. See, as you know, the women tend to lose the blood every month during their menstruation. So some people may have excess blood loss during menstruation, during which time the hemoglobin is lost or the blood is lost. And so the daily iron intake should also be improved so that their iron load also will be balanced. So in order to balance that, the recommended daily intake of iron for the later half of pregnancy is usually increased to 30 milligrams. So absorption of the iron increases threefold in the third trimester. Hence, the iron requirement increasing from 1 to 2 milligrams to 6 milligrams per day occurs during the third trimester. Hence, the iron replacement therapy, the dietary advice, the dietary intake of iron, everything should be on par with this requirement, so that during pregnancy or after pregnancy, the woman will not be having iron deficiency anemia. So how do we know which material has the required iron? The main sources of dietary heme iron are the hemoglobin and the myoglobin, and which is usually seen in red meat, fish, and poultry. Vitamin C significantly enhances the iron absorption. Hence, we advise the woman to take the iron replacement therapy before meals and along with vitamin C, that is the fruit juices, so that the iron which is taken in is absorbed in a better way. Many women have a lot of tea and coffee. One thing we need to remember is that tannins in the tea and coffee inhibit the iron absorption. Hence, during pregnancy, we advise them to limit the coffee intake so that, whatever the iron tablets they're taking will be easily absorbed. Coming to the oral iron therapy, there is something called a trial of iron therapy. In any woman who feels fatigued, who are symptomatic about this anemia, when we give a trial of iron therapy and there is a rise in hemoglobin after 2 weeks, this also confirms iron deficiency. Hence, we can simultaneously diagnose and treat this iron deficiency anemia. Whenever we start the trial of iron therapy, the patients also become very symptomatically improvement in their iron status and in their symptoms once the hemoglobin starts raising within about 2 weeks. And the most important thing is the oral iron is not at all expensive. It is very cheap, effective, and safe, so that we can replace the iron in a safe way. Once the hemoglobin is in the normal range, the treatment should continue for further 3 months so that the iron stores can be replenished. And in the postpartum period, we continue this iron therapy at least until 6 weeks, so that during pregnancy, postpartum, and the replenishment of the iron stores is done. Coming to the parental iron therapy. So what are the indications? See, it is so simple to talk that the oral iron is very easy, cheap, and safe. But there are some people who cannot take the iron tablets. So they would really avoid taking the tablets. So when there is absolute non-compliance in taking oral iron therapy, and there is a persistent anemia, then we have to counsel them and give parental iron therapy. So parental iron therapy is nothing but injectable iron therapy. There are various compositions available for parental iron therapy, such as iron dextran, iron maltose, sucrose, or carboxymaltose. And depending upon the requirement of the iron replacement, we have to give these injections. And usually we give these injections in a diluted form in a saline, run over about an hour or so that it goes slowly and the patient will have minimal side effects. And parental iron therapy is also given when the women continuously have this intolerance to oral iron. That is, the women cannot digest the oral iron. They can have repeated retching, the vomiting sensation, and also they cannot tolerate this oral iron. So because of which we may have to give parental iron therapy. And if the women have malabsorption syndrome, such as irritable bowel syndrome, or if they have a recurrent gastroenteritis, so these people also cannot accept or cannot take the oral iron therapy, and in whom we say that take a parental iron therapy. The one important advice what we give to all the women when we put them on iron tablets is the color of the stool is changed from the normal color to the blackish color, so that is because of the iron, because many women keep asking us the stool has changed its color. So this is a very common thing, and it's nothing to worry about. Now coming to the contraindications for parental iron therapy. So if the woman has any history of anaphylaxis, that is, they do not, there are reactions to the drugs what we use. So some people may have reaction to the iron. So in those people, it is contraindicated. Even in the first trimester of pregnancy, though there is no absolute contraindication, we try to avoid parental iron therapy because we still have about 8 to 9 months with us, wherein we can improve the iron levels by with the help of dietary advice and the oral iron therapy. So in order to that, especially in women with hyperemesis, that is, they have a lot of vomitings and all also. So the iron also itself causes vomitings. So because of which there would be an added vomitings and nausea. So in order to avoid that, we avoid iron therapy during first trimester of pregnancy. And how do we deliver these women? So now that we have corrected the anemia during pregnancy, but if in women who there is anemia still at the time of delivery and they come with late bookings and we diagnose anemia in the later half of pregnancy or during at the time of delivery. So in these people, there is like we need to reserve blood. So the blood grouping and saving has to be done. Inform the blood transfusional department so that the blood is ready, available. So that if the woman starts bleeding, as I told you about in the postpartum hemorrhage in anemic patients, so we need to transfuse blood. Then the active management of the third stage of labor is done, that is the placental delivery. Once, as I would just give you one small information about the third stage of labor is nothing but the placental delivery. After the baby is born, after birth or the placenta comes out. So usually the after birth, when it comes out, there could be a gush of bleeding. So in order to avoid that, we try to actively manage this third stage so that the blood loss would be minimized. And the third thing is blood transfusions. See, depending upon the amount of blood loss, the woman may require blood transfusions. So these are some precautions what we take during delivery. So as a whole, how do we prevent anemia is, one is the dietary advice, universal supplementation. In fact, the government of India has taken up a role that they are fortifying the atta as well as some milk and all with these iron tablets and the folic acid tablets, so that the composition will be at least delivered to the growing children and the pregnant women, so that there could be prevention of anemia. In fact, in most of the government hospitals, we follow that there is a 100-day program wherein the government gives 100 tablets of iron so that the women can take during the pregnancy to, in fact, avoid or prevent anemia. So this is a brief note about anemia complicating pregnancy. And talk about diabetes in pregnancy. As we all know, the diabetes also is becoming increased. Yeah, so a brief note about diabetes in pregnancy. It is management, how do we do it from preconception to the postnatal period. See, diabetes in pregnancy, if it arises during pregnancy or if it is diagnosed during pregnancy, we call it as a gestational diabetes mellitus. And in women who are already diabetic and they are planning for a pregnancy, like, you know, they have type 1 or type 2 diabetes and they're planning for a pregnancy. So that is diabetes complicating pregnancy. So how do we manage this diabetes and its complications in women who are planning pregnancy or are already pregnant? Today's topic is mainly how do we improve the diagnosis of gestational diabetes in all these pregnant women, and if help women with diabetes to self-manage their blood glucose levels before and during pregnancy. So as I said, diabetes is increasing. The incidence of gestational diabetes is increasing as a result of higher rate of obesity in the population, and more pregnancies are planned in the older women nowadays because of the career oriented. So they are becoming more susceptible for diabetes during pregnancy and what we call it as a gestational diabetes. So as you can see the figures, the prevalence, the gestational diabetes is the most common thing, and it is seen in about 87.5% of the women who become diabetes during pregnancy, and that is mainly gestational. Whereas 7.5% of them have type 1 and 5% have type 2 diabetes. The type 1 and type 2 diabetes are usually late, before the pregnancy starts off. So what are the risks? Why is diabetes so important during pregnancy? See, if we categorize these diabetic women, if they have a pre-existing diabetes, there is an increased risk for miscarriages in them if the diabetes is uncontrolled. And because, as you know, the diabetes and high blood pressure or hypertension go hand in hand, there is increased chance of hypertension during pregnancy, what we call it as a preeclampsia. And because when the diabetes is uncontrolled, they have lot of amniotic fluid, and there could be some congenital abnormalities in the baby, and all these can lead to preterm labor. And if the woman already is suffering from diabetic retinopathy, that is the changes in the eye, the changes in the kidney, which occurs before in a diabetic woman, all these can be increased. The complications of this diabetic retinopathy, that is, if they are in the stage 1 of retinopathy, they can go to the stage 2, 3 retinopathy, changes in the eyes. And in the babies, if in the pre-existing women with diabetes, they can have is, if it is uncontrolled, congenital abnormalities. See, what we mean congenital abnormality is, in the babies can develop and heart abnormalities, and usually the spine abnormalities, neural tube defects. So all these abnormalities can occur in the pre-existing diabetic woman. If the diabetes is uncontrolled, the baby can just grow big, and that is called the big baby or the macrosomia. In India, we take it as a 4 kg. Anything more than 4 kg baby, we have to evaluate the woman for diabetes, and also should be informed in the next pregnancy to the obstetrician, because they can evaluate the patient for diabetes during pregnancy. And when you know that the baby is bigger, so the birth injuries can occur and more chances for cesarean section. So, and as the diabetes is uncontrolled, there is more chance for a stillbirth. Stillbirth is when the baby is born without, or when the baby is born dead, then we call it as a stillbirth. So neonatal hypoglycemia, see, the pregnancy itself, it becomes complicated and becomes a high-risk pregnancy if there is diabetes. And even after delivery, the baby also will have problems such as neonatal hypoglycemia. That is, when the baby's sugar starts falling, we need to monitor the baby's sugar after birth, immediately at birth, and as well as every 2 hourly to see if the glucose level is falling for the baby. The babies also can develop some electrolyte imbalances during diabetes, if the mother is diabetic. And there are more chances for the baby to go to an ICU in order to diagnose all these complications to the baby. So how do we help these women with pregnancies? When a woman comes or plans to become pregnant and she's already a diabetic, what we call it as a pre-conceptional counseling, which is very, very important. So pre-conceptional planning and care is the one which gives them an overall picture about when do they plan, and if they become pregnant, how do they monitor, how do they take care, and how do they enter the antenatal care pathway, and then how do they deliver. So all this they need to understand and then plan for a pregnancy. So first and foremost important thing is the advice what we give is, these women with diabetes who are planning to become pregnant, they need to aim for a target plasma glucose ranges. So what are these blood plasma glucose targets? See, when a woman has her fasting blood sugar of less than 5.3 millimoles per liter, or less than 100 or 95 milligrams per deciliter, or when they do a first hour blood glucose level less than 7.8 or less than 140 milligrams per deciliter, or a second hour blood sugar is less than 6.4 millimoles per liter or less than 120 milligrams per deciliter. This is the target range what we advise the women preconceptionally, so that they can plan the pregnancy and that could go uncomplicated. If the woman is got a high BMI, they need to optimize the BMI. See, this optimization of the BMI is the ideal one is they should be around 27, and because higher the BMI, the more the complications for the baby as well as for the mother. So we need to advise, or the woman should continue the contraception till these target plasma glucose ranges are achieved. Continue their exercises so that the BMI can be optimized. So these women who are already diabetic maybe are using some medications. They could be using some oral hypoglycemic drugs. So like, metformin and all. So these medicines, they need to visit their diabetologist or endocrinologist and then review all the medications what they're taking, and talk and discuss with the endocrinologist that they're planning for a baby, so that the alteration of the medications could be done. And during the preconceptional period itself, we need to assess these the long-standing diabetic women, to see if they have any other comorbid conditions such as the eye or the kidney complications, what we call it as diabetic retinopathy or diabetic nephropathy. So we need to measure the HbA1c level to determine the level of risk for the pregnancy. So when a woman comes in the preconceptional period, we assess the HbA1c, or also called as glycosylated hemoglobin levels. And this levels gives us an idea about the previous 3 months blood sugar control. So once the HbA1c level falls less than 6.5%, then we can advise them to go in for a pregnancy or a plan for a pregnancy. And also, if the woman had a history of gestational diabetes in the previous pregnancy, then a 75 grams 2-hour oral glucose tolerance test is done once she conceives in the first trimester itself, because this gives us a overall idea whether the woman will again have a gestational diabetes during pregnancy. So whenever we do this 2-hour oral glucose tolerance test with the 75 grams glucose water, what we achieve is, we need to do the fasting blood sugar in these patients, give a 75 grams glucose water, then we take a 1-hour blood glucose, and then we do the 2nd-hour blood glucose. So these levels also should be maintained. In the fasting should be less than 90, first hour should be less than 140, and the 2nd hour should be less than 120. So whenever we do this 75 grams oral glucose tolerance test and the target plasma glucose ranges are achieved, then the woman will be in the safe hands, and then but still needs to be monitored for the gestational diabetes mellitus. So what are a word about the risk factors to develop this gestational diabetes mellitus? So when a woman has a previous history of diabetes during pregnancy, or when they have a family history of diabetes, that is the mother, father, sisters, anybody has the diabetes in their family, or the third part of it is if the woman has a macrosomic baby, that is the baby is more than about 4 kg in the Indian standards, or if the woman already has preeclampsia, then we have to, or the high blood pressure, we need to see for all these diabetes during pregnancy or the gestational diabetes, and then evaluate accordingly. So coming to the antenatal appointments for this. So now that the pregnant woman has who is a diabetic has become pregnant, how do we take care of her during pregnancy? So once the booking appointment, so when they come in the first, once they miss their period, we have a good long chat with them, counsel them about the pregnancy, about the need for the dietary advice, about the need for controlling the blood sugar levels, and they should follow in a joint clinic, that is in a multidisciplinary team management, that is the dietitian should be involved in the loop, the obstetrician as well as the endocrinologist and physician should be in the loop. They need to have a joint appointments with the obstetrician and the endocrinologist, so that the target plasma glucose levels can be maintained throughout the pregnancy, and that can decrease any morbidity to the pregnant woman as well as for the baby. So once the woman comes for the booking, first we need to do a viability scan, that is to see if the baby's heartbeat is seen, and this is usually done at around 7 to 9 weeks. So once the viability is done, then the blood sugars are monitored, and if, as I said, if the woman is already having a GDM earlier in the pregnancy, then she will undergo a 75 grams OGTT in the first trimester itself. And if the woman has any risk factors, or if she already is a diabetic, then we do a HbA1c level. Then once the 7 to 9 weeks viability scan is done, then we ask them for a monthly checkup. And at the monthly checkup, we advise them about the diet, about the need for the oral hypoglycemic drugs or insulin therapy if the diabetes or if the sugars are not under control. And they have to be booked as a high-risk pregnancy in the antenatal care pathway. Then we need to assess their retina, their the kidney function test in the first booking itself, so that we will know whether the eye as well as the kidney are functioning normally, or is there any deterioration in these vital organs. So as in any other pregnant women, we advise them at 12 weeks for their routine NT scan as well as the double marker test, or to see if the baby is got any genetic problem which we can diagnose it, such as, for example, the Down syndrome. So when we do a scan and for the NT or the nuchal translucency at 12 weeks, we also evaluate on a gross whether the baby has any other neural tube defects. So find out whether the woman was on folic acid preconceptionally. 5 grams they need to take and continue throughout the pregnancy, and if so that the neural tube defects can be prevented in these women. Now coming to the end, after the NT scan, we ask them to come every 4 weeks, and at 16 weeks we advise them to get their routine scan done to see how the baby is, or what sometimes what we call it as an early TIFA, and continue the iron and calcium supplementation. Then dietary advice needs to be taken, and the insulin should be given according to the requirement. And at around 18 to 20 weeks, we do the same anomaly scan, and from 28 weeks onwards, we have to do the growth scan. There will be a special scan for the women with diabetes called a fetal 2D echo at around 24 weeks, because to see the congenital heart abnormalities which are more common in the women who have diabetes. So as the pregnancy is going on, then we do the growth scans, and by 37 to 38 plus 6 weeks, in type 1 or type 2 diabetes, we offer induction of labor so that the baby will not become big or macrosomic. Whereas in a woman who's got a gestational diabetes mellitus and it is well under control, we wait for a spontaneous labor, but we advise them not to go beyond 40 plus 6 weeks or 40 weeks. So during this time, the fetal well-being tests are advised, so that the baby needs to be assessed by what we call it as an NST or a non-stress test or a CTG, as well as, if required, see in the ultrasound to see how the baby is doing. How do we manage the postnatally these diabetic women? The lifestyle advice. See, the weight control has to be followed, including after delivery, so that their BMI will be maintained less than 30, so that at least the future, if the woman has got a diabetes during pregnancy, the future diabetic status can be at least postponed or under control. The dietary advice also should be continued so that they would not become overt diabetes. Exercises are very important. Hence, the lifestyle advice and lifestyle modification for these pregnant women with diabetes or gestational diabetes is very, very important. So usually what happens for the glucose or for the diabetic status in these women? So as soon as the delivery is over, the gestational diabetes mellitus pregnant women, the glucose levels will become normal as soon as the baby is born. Hence, they will be advised to stop taking insulin or the oral hypoglycemic drugs such as metformin after the delivery. But they should keep a watch on their blood sugars. In women who are already diabetic and became pregnant, after delivery, they go back to their pre-pregnancy blood sugar management protocol, so that the blood sugar will be maintained with the old medication. To all these women, we need to check their fasting plasma glucose after the delivery once between 6 to 13 weeks. And if it is normal, then they have to be just under a follow. But if the HbA1c or glycosylated hemoglobin. If the woman has forgotten or she did not do a fasting plasma glucose between 6 to 13 weeks, we advise them this glycosylated hemoglobin test. So whatever the test they do, but to be cautious, advise them annual glycosylated hemoglobin test so that we can diagnose them whether they are becoming over diabetic in future. So this is a brief note about anemia complicating pregnancy and the diabetes in pregnancy. So thank you. If you have any questions, I will be ready to answer. Thank you.